Buckle your seatbelts and get ready for this fantastic voyage. I am going to teach you today about a new acronym that, well, it may not be new to you, but it's new to some nursing students and definitely new to some new graduate nurses going through their respective orientations in their hospitals, if the hospital is where you choose to work. Let me introduce you all to MINOCA, myocardial infarction with no obstructive coronary arteries. You're probably asking yourself, well, isn't that just the same as Prinzmetal's angina? The answer is no. Now, while Prinzmetal's angina or coronary vasospasm is a type of MINOCA, it is not the only presentation where this occurs. What are the other ones? Fantastic question. Now, before we get into the other ones, let's clarify. Prinzmetal's angina, coronary vasospasm, no obstructive coronary disease is found by way of coronary angiogram or heart catheterization. But during this same heart catheterization, the cardiologist will inject nitroglycerin, intracoronary nitroglycerin, during the case to see if we have an element of Prinzmetal's angina. Now, once this intracoronary nitroglycerin is introduced, the coronary arteries will dilate or widen like they're supposed to. But then if they instantaneously spasm or clamp right back down, you've confirmed your diagnosis of Prinzmetal's angina. Treatment options will likely include calcium channel blockers. There's a presentation or a post that I've already done about that. If you're interested in learning about that, no worries. Check out that post. All you got to do is hit that little plus sign right there. Go back to previous posts that I've done, and you'll see a header just like this that goes over Prinzmetal's angina. Moving forward, other presentations of MINOCA, the most common of which is myocarditis. Myocarditis accounts for 30 to 35% of all MINOCA cases. And if you think about the logic behind it, like the pathophysiology of it, makes perfect sense. Myocarditis, what is that? Student nurses are probably asking. Look at the word itself. Look at the diagnosis. Myocarditis, break it down into its parts. And I've told you before, I'm a big geek about word etiology and etymology. All you got to do is look at the parts. Most of our medical terms are derived from either Latin or Greek origins. This one is no different. Myo, meaning of the muscle, of or pertaining to muscle. Card, coming from the word cardio, heart. And then itis, the suffix, comes from a word meaning inflammation. So an inflammation of cardiac muscle, that is myocarditis. Well, with this inflammation of cardiac muscle, if it reaches a certain point, then there's going to be some damage done to those cells that make up the myocardium. And remember, the myocardium is the muscular portion of the heart. It's the middle layer. Anyhow, if there's enough inflammation to this myocardium, then that is going to lead to damaged cardiac cells. What protein gets leaked out when cardiac cells are damaged? Troponin, absolutely. Troponin rises get to a certain point, you have what is called demand ischemia. Big old fancy word. It's a type 2 MI, heart attack, MI. MINOCA, no obstructive coronary disease whatsoever. Myocarditis comes with its own set of treatments. We will get into that another time. I just wanted you to know that that is the primary culprit behind MINOCA. Following at a very close second is Prinzmetal's angina. Subsequent to that, you have anything from SCAD, which is spontaneous coronary artery dissection. That happens when the arteries that bring blood flow into the heart, those are your coronary arteries, the layers that make up the coronary arteries, because remember, the artery wall is not just one solid thick piece of tissue. It has layers, like a layer cake. And if those layers begin to tear apart or dissect, that's what that's called, ouch. Ouch. And you're getting right back into demand ischemia from troponin release. There's another presentation I've already done on spontaneous coronary artery dissection. Y'all know I geek out about this stuff so much, and I'd like to talk about cardiology, so you can find those posts. Same thing, hit the button, go back in time, you'll find a post just like this that says SCAD, S-C-A-D, spontaneous coronary artery dissection. Anywho, Prinzmetal's angina, myocarditis, SCAD, and then another big one that causes this is clot burden, intracoronary clots that can happen for a host of reasons, but just understand the take-home point. There's not any obstructive coronary disease that is causing this myocardial infarction. Oh, I would be remiss if I didn't say this one. Sometimes patients will undergo their respective cardiac workup, and maybe non-obstructive disease is found. Maybe there's like, 10, 20, 30% plaque burden. If that plaque should rupture, cause a blockage, and it doesn't necessarily have to be a blockage in one of the major arteries, could be a blockage in one of the branch arteries as the result of plaque rupture. MINOCA, because remember, there was not obstructive disease to begin with. Bringing things to a close, because again, I find myself getting a little enthused. I got to bring myself right back down. MINOCA, myocardial infarction, heart attack, secondary to non-obstructive coronary arteries, non-obstructive coronary arteries. There's no significant blockage of 70% or greater. You have a lot of different diagnoses that fall underneath that umbrella, but these are not interchangeable terms. All Prinzmetal's angina falls under MINOCA, but not all MINOCA is limited to Prinzmetal's angina. Same thing, not all MINOCA is limited to SCAD. Not all MINOCA is limited to clot burden. You see the difference? That will conclude it for today's lesson. If I can clarify anything or add any additional information, you guys know how to reach out to me. If you guys have experienced patients with MINOCA, chime in. Your classmates are eager to hear from you. This is an open forum. It's not just me giving you information. I learned from you guys too. All that said, class is officially dismissed.